coming to our hospital. We had no capacity. This is why we had a large amount of patients with COVID infection. So in summary, the study we did is a retrospective data. We looked at the medical records. We have the electronic recording system, which summarized all the data, the biographic data, the age, ethnicity. We looked if they have pre-existing liver condition, if they have cirrhosis. We also looked at the outcome of the patients, where they discharged, did they die, did they go to ITU, and also we collected their blood test and we looked at the pattern. The liver enzymes, the bilirubin, and we divided them into have abnormal liver blood tests during the COVID infection, but we looked at the follow-up data. So we looked at the short-term follow-up up to 6 months after discharge, and we looked at the long-term data from 6 months up to 12 months after discharge. So we were very, very interested to see if acute COVID infection will lead to a chronic liver disease. Up to the, and we know the alkaline phosphatase is more of a biliary or cholestatic picture. So a ratio of more than 5 will indicate a hepatocellular. A ratio between 2 will indicate of more cholestatic picture. A ratio of R between 2 and 5 is a mixed picture. So when we say it's a mixed picture, means there's a mixture between rate of alkaline phosphatase and ALT. When it's hepatocellular, then it's predominantly ALT, and if it's cholestatic picture, then it's predominantly alkaline phosphatase. So this is a summary of the results. I won't take long. I know Professor Amran is keeping an eye on the watch. So basically, majority of the patients were among the productive age between 20 to 50, but the range scales between 20 to 100. The oldest patient we had is 98. The samples were predominantly made of men. This is a very interesting finding, which we couldn't see it in other studies. The average stay of the hospital was 17 days before discharge. When we looked at the data, you can see we had 373 patients admitted. 9 patients unfortunately died, and so 9 of them had liver disease, and then 100 of them died during the hospital. Of them, half of them they had abnormal liver blood test. So this is an indication that patients with abnormal liver blood test, they have 50 chance mortality rate. Then we followed up 250 patients who were discharged successfully from the hospital. When we looked at the R factor, and remember the R factor is a pattern of the blood test, the majority of the patients, they are either cholestatic or they are mixed hepatocellular and cholestatic. And this is, if you remember back to the etiology of abnormal liver blood test, we said that the angiotensin receptor enzymes receptor is in the cholangiocytes, and this is the portal entry of the COVID virus infection. And that's why we have a more cholestatic and mixed. The hepatocellular is more reflective of the liver ischemia or the drug-induced liver injury, but we have a very nice combination of both pictures. When we followed up the data, so we looked at the data for those who were followed up to 6 months and those who were followed up to 12 months after that. You can see 134 patients had blood tests done up to 5 months after, and third of them, remember, third of the patients who were discharged continue to have abnormal liver blood tests after 6 months. And then we looked at the data for up to 1 year following discharge. We had the data from around 100 patients. Quarter of them, 24% of those patients, continue to have abnormal liver blood tests up to 12 months after discharge. And remember, those patients did not have abnormal liver blood tests before admission with COVID. They did not have any other chronic liver conditions. So the theory or the hypothesis here is whether COVID can contribute or can trigger some sort of chronic liver disease. So this is so the few is published about the long-term follow-up of COVID. There's plenty of paper in the literature about the acute derangement of liver enzymes, but I didn't see many papers about the long-term follow-up. I'm sure more data will come on. This is currently in press and will be published very soon. We have seen the majority of the patients, half of them, they had abnormal liver blood tests during the admission. Third of them, they continue to have abnormal liver blood tests up to 5 months following discharge, and quarter of those patients, they had abnormal liver blood tests after 12 months. And the pattern of the liver blood tests were between cholestatic and hepatocellular. Our data is supported by the other literature, other papers in the literature about the abnormality in the liver blood test and the COVID infection. The majority of the patients who had severe abnormal liver blood tests were admitted in ITU. What is new in our data is male had predominantly more likely to develop abnormal liver blood tests compared to female patients. And we don't know why, but this is something that we can explore later. Obviously, our study is limited. There's no perfect study. As I was taught by my teacher, Professor Amran, we are limited by our population. Remember, Northwest London is mainly ethnic minorities. It does not reflect the whole country. We didn't have the full drug history of patients because we relied on electronic system, which is ePro. They don't always accurately reporting the drugs given in ITU. And remember this study based on patients who reported to their GP up to 12 months. So we only identified those who actually had blood tests. We didn't ask them to come to the blood test. So this is more of an opportunistic study to look at those who had abnormal blood tests. And obviously, if you have abnormal liver blood tests, you're more likely to go to see your GP. So we are missing some group of patients. I think I'll be done here. Just in summary, acute COVID infection is associated with acute derangement of the liver blood test. The study suggests there's a good correlation between severity of the liver blood test and the outcome, including mortality. We did identify there is a quarter of patients who were discharged following COVID. They continue to have abnormal liver blood tests, and whether there is a theoretical or hypothesis question to ask here. And it's very important to consider this when you look at the long-term outcome of patients with COVID, example, the COVID syndrome, the fatigue syndrome after COVID. And I am done. Thank you so much. أخاف منك. أنا أبقى تلميذك. لا احتراما. أشكرك أستاذ. بالعافية. شو تخليها دكتورة؟
إن شاء الله. السلام عليكم. Psychiatric morbidity among patients with coronavirus in Basra city. COVID-19 presents a serious threat to mental health around the globe by elevating rate of anxiety, depression, and PTSD and negative societal behavior. Deep emotional trauma and societies overwhelmed by large-scale human disaster like global pandemic disease, natural disaster, man-made tragedies, war, conflict, social crisis, etc. can cause massive stress-related disorder. WHO technical guidance notes stated that the main psychological impact to date is elevated rate of stress or anxiety, with a warning that as a new measure and impact are introduced, especially quarantine and its effect on many people's usual activities, routines, or livelihood, level of loneliness, depression, harmful alcohol and drug use, and self-harm or suicidal behavior are also expected to rise. The lives of people were drastically affected with lockdown and fear related to the disease's potential effect on and transmission. The fear due to the contraction of COVID-19 is on the rise because of the death percentage and international spread. The fact that the method of transmission through community convergence require a special pattern of accurate preventive measures such as wearing masks, sterilization, and washing hands, which affect the normal lifestyle and normal human behavior, resulting in various and multiple psychiatric disorders such as depression and anxiety, OCD, psychosis, especially among patient with this virus. For the purpose of knowing and diagnosing these disorders and for the purpose of treating them side by side with medical remedial procedure, this research tries to shed some light on the mental consequences of COVID-19 patients, putting in mind that their negligence will negatively affect the patient's life. أكيد طبعا the aim of the study is to collect and analyze and interpret psychiatric symptoms and to give a possible psychiatric disorder accompanying COVID-19. The method, the study was a case control study carried out at البصرة Teaching Hospital, and as we know, this hospital was recently decided to be a specialized center for management and follow-up patients with COVID-19 during period extended from 1st of April and to the end of June. It was conducted randomly about in 100 patients who attend the COVID-19 outpatient and 100 control from general population at the same age and at the same time period. We include in the research all cases that have been diagnosed and admitted to the infectious ward, and the age group was 12 and above were included, and the exclusion criteria: patients who have a psychosis or any psychiatric disorder secondary to organic disorder or substance abuse, and patients from other southern cities. Both group, patient and control, were surveyed for the presence of psychiatric disorder by using a general health questionnaire and the application of diagnostic and statistical manual DSM-5 for diagnosis of the most common psychological disorder, and data were entered into personal computer using SPSS version 20. The result, as we see, the phobia, panic disorder attempt, and others were not reported neither in cases nor in control group, and generalized anxiety disorder and depression were observed in higher percentage in cases than in control. And the observed difference was statistically significant when the p-value less than 0.05. Neither the history or psychological disorder nor severity showed significant statistical differences between the two groups. And regarding the basic characteristic in relation to generalized anxiety disorder in the sex, we found that it's more common in male than in female, in age group, more common in 12 to 30 years, and in occupation was more common in officer. This is regarding the most important regarding the generalized anxiety disorder. And depression, in contrast, it's more common in female and in age group the same, and occupation also in officers. Discussion. The correspondent study showed that the psychological impact of COVID-19 pandemic on the affected population and non-infected population in Basra city. The study found that the psychological impact of COVID-19 mainly represented by depression, around 49% in cases and 32% in control, generalized anxiety disorder 32% in cases and 16% in control, and other disorders by 25% and 16 cases and control respectively, which as shown represent an increase of impact in the cases group in comparison to control group, which can be attributed to the effect of the virus and its physical insult on one hand, and to the psychological impact of the quarantine, worrying about their health and fear of death, the increasing anticipation of disease complication and its effect worldwide. In a pool of citizens, a study found a 21% psychological burden, which resembled percentage of PTSD 28% and depression 31%, which is less than the percentage of our study. And a study done in India, which covered 63 cities with 653 respondents overall. Among the 653 respondents, 33% had significant, mild, or moderate and severe psychological impact regarding COVID-19, mainly anxiety and insomnia. Our study showed that there was a correlation between having a history of psychological disorders and an increased psychological impact of COVID-19 in both cases and control group by percentage of 13 and 10% respectively, but without significant statistical association. This was on contrary to the screening of American Mental Health Organization, which revealed significant increase in anxiety and depression screening. The per-day number of anxiety screenings completed in May was 370% higher than in January. Before coronavirus threats began, the per-day number of depression screens was 394% higher in May than January. From demographic variable point of view, the study found no statistical association in the prevalence of depression in female and male in cases of COVID-19 by prevalence of 51% and 49% respectively, which is inconsistent with the result of India study. Younger age group were associated with percentage of correlation with depression and anxiety in cases group, but it is of a statistical insignificance, which is opposite result to a study in India, America, and China. This can be explained by lack of variability and a small study size. We conclude that COVID-19 has caused a great burden on health, not only on physical aspect, but also on mental and psychological aspect. Our study revealed a psychological impact of COVID-19 represented by depression, anxiety disorders, and affective instability. Generalized anxiety disorder and depression were observed in higher percentage in cases than in control, and this observed difference was statistically significant. Officer and student were most to be affected. Younger age group was found to be the most prevalent of psychological impact, but without statistical significance. Although there is a correlation between previous psychiatric history and the increase of psychological impact of COVID-19, but also this correlation is not statistically significant. Thank you very much.
يعني أنا ريلاكس شوي. Thank you, Mr. Chairman.
Thank you.
بعد راح الحكمة راحت.
Allow me present my case report for thoracoscopic repair.
شكرا.
The affirmative care.
I'm sorry. كثرت طلاتي ربما أمل. Yes.
Sister Prof. Pediatric surgeon.
It's a feeling of death. ممكن إلى مسمى thanatophobia.
Children's
It's a
specialty.
form of anxiety characterized by apprehension about one's death or the process of dying. In the context of current pandemic, death anxiety appears especially relevant not only on the short-term basis, but also in predicting future mental health consequences.
It is a congenital anomalies, and congenital means the baby born with this condition. So at present,
concerning death and
embryological structure
in the last moment, every group, community, or
generally,
society has its
in the early
own
stages of fetal
customs and
development, there is
rituals
what's
for
called
death and mourning.
pleuroperitoneal canal, and
Yeah.
this pleuroperitoneal
March.
canal going to develop a septum that separates the thoracic cavity from the peritoneal cavity. So diaphragm comes to separate these important structures to be totally independent, surely with some orifices that affect the passage of certain structures like the esophagus.
Okay, sorry.
Inferior cava.
There are differences in such rituals and
There is a
customs
difference.
from one culture to another. However, they share a
congenital
key
diaphragm-
ingredient that
diaphragmatic
is
hernia
the
going
social
to,
connection.
result
تكون
with
مشكلتنا في البداية خصوصاً
herniation
من
of
غير
some
الفيلم of
abdominal
death
viscera,
وين راح يندفن
including
زين ولا
the
مرينا
sometimes
بمنص
liver, spleen, and even
قاسية
kidney.
جدا
And
زين
in
ولا
one case I find
يندفن بمكانات
abdominal
بعيدة
viscera
ما راح
here
يروح
in the
للنجف
chest.
إلى
So,
أن بعدين
many
حصلنا
other,
في ديسكشن ويا الصحة العامة ببغداد وفضينا من الشغلة لأن هي ما بها scientific
could be
basis
found,
إنه ندفن
chest.
على طبقات.
So congenital diaphragm
To highlight the topic of death feeling among the COVID-19
As a-
population and to estimate its
2,500
prevalence and determinants among hospitalized
Evolutional
patients,
advances
to assess whether there is a
management,
relationship, this is the
congenital
point,
diaphragm,
between this feeling and the actual short-term
anomaly,
mortality outcome. This
mortality,
was observational
significant morbidity and
cross-sectional
long-term,
study held on
disability.
560 hospitalized patients with COVID-19 in Basra from January 1st to the 1st of December 2021. دايركت انترفيو، يعني احنا محطات خلينا ضمن الكويشنير بالكشيت مالته انه asking بطريقه about feeling of death، شو تشعر؟ خايف تموت او خاف من الموت بطريقه يعني ما فيها هوايه harmful، وبعدين بالنهايه نشوف الاوتكم مالته معظمهم most of them more than 90% هم كانوا بالاي سي يو، نشوف الاوتكم. Subsequently, medical record assessment is considered to register the patient's clinical data and short-term outcome at hospital discharge. إذا كان discharge or 322 males and females were evaluated with a mean age of 57.16. The results showed that the feeling of death occurred in about half of the patients. In terms of gender distribution, ماكو much difference تقريبا statistically not significant between the male and female. The prevalence increases significantly in a linear manner and increasing with increasing age. Those اللي هم under 35 years كان 21. كل ما نصعد بالage إذا يوصل ل 65 the feeling of death يكون أعلى. Characteristically, the rate of photophobia occurrence is equal to 97.8 among intensive care unit patients. يعني اللي هم بالانتنسيف كير يونت كان most of the feeling death عندهم اذا قارنا ويا اللي موجودين بالميديكال وورلد. The occurrence of thanatophobia significantly increased with decreasing oxygen saturation and disease severity. Those اللي هم oxygen saturation يعني severe من 70 إلى 93 يعني على الأقل below 93 يكون 13%، بينما اللي هم below 70 راح يكون 98.4%. A significantly higher prevalence is also associated with those who have chronic medical illnesses. يعني اللي عنده comorbidity كأنه ما يشعر خلاص this is the end، هو عنده منها diabetes وhypertension أو أي kept on cytotoxic وبعدين تجي الكوفيد 19 يعني وصلت مرحلة كأنه ما يجون يقول يعني لازم أكتب بسيطي يعني like this. فالبيشنتس حقيقة اللي هم such severe apprehension راح يدخلون severe time. 97% of those who ended with death had feeling of apprehension during their illness, while only 2.9% of died patients have no thanatophobia. And also 23.9% of those who have had the feeling of death actually died, and 0.7% for those with no death feeling. This can statistically very significant. On discussion, death anxiety is affected by many factors. And these include the gender, marital status, age, belief, frequency of encountering death, near-death experience, خصوصا إذا كان عنده family history of death، العملية تصير كلش صعبة. However, in general, individuals can feel death anxiety intensely when they feel their own lives are indirectly in danger. Current evidence suggests that COVID-19 pandemic causes more death anxiety, mostly in healthcare workers. Unfortunately, our colleagues اللي هم 12 كانوا died because of COVID-19 كان عندهم feeling of death عنيف. يعني الأطباء الشهداء كان feeling of death عجيب. When it comes to family and children, it can be thought that women are affected more psychologically. Death anxiety can lead to situations such as loneliness, depression, increasing the frequency of hospital admission, and during the COVID-19 pandemic process reported higher death anxiety and suggested that women may experience more death and more death anxiety. Although there is no systemic review reporting death anxiety seen during COVID-19, some studies have addressed anxiety or death anxiety in races and professions. In particular, the death anxiety rates of healthcare workers who are at the center of fight against COVID-19 pandemic are very high. It has been stated that old age has been an important risk factor since the beginning of the pandemic. And the high prevalence of death anxiety among the elderly is due to many physical problems, chronic illness, movement disorder, physical disability, dependence on the others. It's also known that during period people's lives are more prone to anxiety due to reduced activity and mobility and loss of frame, reduced financial, physical independence, and chronic. طبعا هو السؤال هذا المهم جدا. Is it the death feeling being a result of severe disease or it is a cause? Is it related to rapid disease progression? طبعا أكيد يعني patients rapidly progressing يدخل cytokine نفسه ممكن يولد لنا apprehension. Has any organic base اكو علاقه واضحه ما بين الستريس فاكتورز وما بين الاميونيتي تشينجز. هسه مو بالضروره لو اميونيتي، احنا عندنا what we call the psychoneuroendocrine. Most of patients were in the ICU and the frequency of cytokine storm was higher, which actually it needs more and more concern. اكو شيء اللي هو psychoneuroimmunology اللي ممكن يفسر لنا is now providing key mechanistic evidence about the ways in which stressors and the negative emotions that they generate can be translated into physiological changes. The immune system communicates bidirectionally with the central nervous system and endocrine, and how these interactions impact on health. Acute stress, increasing immune response, and immune dysregulation, وممكن releasing of interleukin. And then after راح ندخل بالمتاهة of the organs dysfunction and organ destruction. Phobia is common phenomena that occur in COVID-19. Furthermore, long-term evaluation محتاج cognitive behavioral therapy are required for survival to prevent mental health illness. طبعا acutely also aggressive reassurance is mandatory. حاولنا قدر الامكان نعملهم reassurance هسه by somebody to reassure them or be some anxiolytic. ربما SSR inhibitor عملنا can effective to some extent. Leproxide, a simple anxiolytic during the time of acute illness to relieve anxiety and achieve. And thank you.
Assalamu alaikum. Thank you, Dr. Laith, for your nice and informative presentation. In fact, still there are a lot of questions regarding the linking between COVID and liver and abnormal liver function test. Still not solved, including is the COVID virus is a hepatotropic virus or not. My question is about those patients who have a persistent elevated liver enzymes beyond 6 months. Did they are investigated more deeply? As we know, there is a lot of connection between the COVID-19 and the linking between COVID-inducing autoimmune hepatitis, COVID-inducing primary sclerosing cholangitis, and those inducing primary biliary cholangitis or cirrhosis. And another question, I think there in England, those patients who are died, I think there are 9 patients, did they undergo autopsy or the autopsy was forbidden for those?
You mean the recent?
Yes.
That's okay.
And thank you very much.
And it's a pleasure. Thank you so much. Very clever question, and well done for asking the question. We followed the data up to 12 months following the discharge. We did not do any liver biopsy or further investigations. They're currently coming to my clinic. I keep following them up every 6 months. We've done elastography, fibroscan to make sure they don't have any evidence of fibrosis or a beginning of cirrhosis. So none of them so far. But they haven't triggered the threshold for liver biopsy because, you know, the liver biopsy normally considered when you have 3 upper limits of normal. So they do have abnormal liver blood test, but we haven't actually looked deeper. Obviously, to expose them to a liver biopsy just to answer a question is not ethical. But, you know, at the moment, the LFTs are settling down generally, and there's no evidence of chronic liver disease. They're fit and healthy. We suspect, and this is just a hypothesis, not been confirmed yet, we suspect those patients, they have an element of underlying fatty liver disease. And the COVID infection triggered some sort of reaction, as you said, which similar to steatohepatitis, because, you know, we don't know. Still unanswered questions regarding COVID. But what I have seen, those patients that they come to my clinic with prolonged abnormality in liver blood tests, they still have a long COVID syndrome. So some of them, they still report fatigue, tiredness, lack of energy. So maybe there is a link between the 2 conditions. We haven't explored this yet, but it's still a very, very good area to explore. With regard of the last reports of death in UK and the world, in children, you mean, the pediatric ones. As far as I know, they did not go through autopsy. We don't know what's causing it. It's still an unknown. I think the situation is slightly better now. I spoke with one of my pediatric hepatologists in King's College, and he said things are settling down. They don't know the exact answer why those children have this sort of flaring hepatitis, but no autopsy. Thank you.
We know already we have a lot of the patient, and also you did the scheme of the treatment. I have ordinary question. What you feeling the origin reason for the death for the COVID your patient when you have what I mean to say that for the treatment or from our immune system invasion or from the viral invasion? Your feeling, what is the critical point for the death, please? Honestly and really.
Thank you. It's not feeling. It's multifactorial. And sometimes death because of the complications. For example, cardiac insult, cerebral insult. إضافة the main cause لما يكون severe وprogressive وواصل للcritical راح يكون أكيد respiratory failure and of course in addition sometimes bacterial infection, sometimes fungal infection. It's a multifactorial. But definitely because of the virus and sequence.
Yeah, so that's why I ask about your experience, what you see. So sure, some risk factor near to your brain That's maybe this is the factor for the death or complication or
One
nothing.
of the main, or what the main cause of death is the cytokine storm. Yes, sure.
Thank you very much.
Thank you.
شكرا دكتور علي. السؤال الأخير دكتور. منو؟
السؤال الأخير الدكتورة هبة. مثل ما تعرفون الكوفيد تبعاته هي اقتصادية بالدرجة الأولى، وحل الأزمة الصحية للكوفيد هو إنعاش للاقتصاد، هذا معروف. بس مشكلتنا بالكوفيد مثل ما حكت الدكتورة هبة هو البوست تروماتيك ستريس ديس اوردر. هواي ناس يمكن دكتور علي يتفق وياي يقول ورا الكوفيد على قولة المصري أنا مش أنا. يعني شنو أنا مش أنا؟ تركيزه يقل، السكيل مالته تقل، طالب دراسات ما يقدر يكتب رسالة الماجستير مالته، يقول ما أقدر، ما قاعد أركز. طالب كلش شاطر بالمدرسة درجاته قامت تقل. behavioral changes، يعني أكثريتهم يعانون من nightmares، insomnia. فمشكلة البوست كوفيد psychological disorder worldwide يعني كلش مهمة. احنا بالبصرة بالعراق شلون يعني عالجناها؟ فتحنا مثلا اوت بيشنت لهم، سوينا لهم كلينيك خاصة لهم.
والله يعني صراحة هو ماكو هالشكل شيء، بس تعرف انه هو احنا موجودة الردة النفسية مفتوحة دائما، وطبعا موجود ايضا مركز سارة اللي هو خاص بالعلاج والدعم النفسي والاسناد الاجتماعي، اللي هو ايضا تابع دائرة الصحة عفوا. وطبعا العيادات الخاصة ايضا موجودة، فهو اكو فولو اب للبيشنتس اذا هم يردون يراجعون. بس طبعا صحيح مثل ما حضرتك قلت دكتور انه احنا شفنا انه هوايه من المرضى بوست كوفيد يعانون من مشاكل بالتركيز. طبعا هي هم ترجع اسبابها الى اصلا وجود الاضطرابات النفسيه، يعني كانكزايتي يعني جنرالز انكزايتي ديس اوردر، كدبرشن مثل ما قلنا انه هي تزيد بالكيسز. فطبعا هذه كلها هي اصلا تاثر على التركيز، تاثر على الكونسنتريشن. يعني هي واحده من الاعراض مثلا اللي موجوده بالدبرشن هي لوس اوف كونسنتريشن او ليس اوف كونسنتريشن خلينا نقول. فطبعا اكيد كل هذه الاسباب هي ترجع اللي ممكن اكثر تزيد عند المرضى اللي يكون عندهم كوفيد 19. بس انه احنا شلون عالجناها ما فتحنا شيء زايد صراحه، بس هو اللي موجود اعتقد كان يفي بالغرض نوعا ما. بس احنا ما عندنا علم دكتور، ما عندنا سايكايترست يداوم بهالشكل بالكلينيك يعني. اكو، بس قصدي انا كسايكايترست احنا ما كان عندنا يعني.
شكرا.
شكرا دكتور. احنا حقيقة قبل ما نختم نعطي فرصة للسيد رئيس الجامعة، لأنه يعني هو يمكن المحرك الرئيسي مع طبعا الإخوان الآخرين للمؤتمر. وأنا أقول كلمة، أنا حسيت في هذا المؤتمر أو في يعني خلينا نركز على هذا المؤتمر. واليوم أكو إنتاج للعلم. أنا دائما من القائلين نحن نقرأ العلم، ننقل العلم للطلاب، بس ما ننتج علم. أنا أعتقد من خلال بعض العروض لهذا اليوم نحن بدأنا ننتج العلم، ولذلك علينا نوثقه. يعني أنا دكتور علي ما راح أتيهك، المحاضرة الأولى والثانية يعني إذا ما نكتبها بالعربي نكتبها بالإنجليزي. أنا أسوي لك مشروع ثاني والدكتور موجود إن شاء الله يدعمنا، والمعقل هم يدعمونا. دكتور سعد حياك الله.
شكرا جزيلا
وإلك المنصة.
شكرا جزيلا. السلام عليكم ورحمة الله وبركاته. أنا بس أردت أذكر أنه البحوث صراحة راح تنشر في مجلة سكوبس خلال مذكرات التفاهم والتعاون اللي موقع بين جامعة البصرة كلية الطب وجامعة فردوسي في إيران. فإن شاء الله البحوث كلها يعني راح تكون طهران، العفو، جامعة طهران الطبية، جامعة طهران واي سكوبس إن شاء الله المجلة. كان عندي سؤال دكتور ليث من كان واقف على المنصة، عفوا راجعك مرة ثانية دكتور ليث. If it was correlated this liver injury with other organs involvement, especially the percentage of involvement of the lungs or kidneys or brain or the state of bleeding, example D-dimers or the rest. او اللي مهمه عندنا بصراحه هو الانتي فايرال تريتمنت whether these patients receive antivirals which type or not. شكرا جزيلا.
شكرا جزيلا استاذ دكتور سعد. بالنسبه للseverity of the lung involvement, those who had severe lung disease they went to ITU and 50% of them they died. Those who were discharged they had mild to moderate lung involvement based on the CT scan staging of their lung disease. So those who we followed up to 12 months, they were 50-50. Half of them, they had severe lung disease and half of them had mild or moderate lung disease after discharge 12 months later. With regarding remdesivir, the antiviral which were given, half of them, because when we started in March, the data was collected from March 2020 till May 2020. There was no availability of remdesivir. It came just towards the end. At that time, we were just giving steroids. So most of them did not have remdesivir during the admission. We are having we have a cohort of 1,000 patients after this data collected. So we're looking at the second sub-analysis of the data. But as far as we know, remdesivir was not included in this cohort. Thank you. Just one note من رخصة الأستاذ. بالنسبة للجامعة أنا طبعا من خريج البصرة قبل 20 سنة ودائما أفتخر أنه أنا يعني ابن من أبناء الكلية. يعني صراحة I'm very happy. Honestly, I'm seriously happy, proud to be part of this. وذاك يوم سعد أحشي دكتور جواد إنه الأشياء اللي تعلمتها بالclinical pharmacology, other specialties, epidemiology, still I practice it despite يعني صار لي 20 سنة طالع. Thank you so much, and I'm very honored to be part of this conference. And good luck everyone, my colleagues, students, and respect to my teachers and supervisor. Thank you so much.
شكرا دكتور لك. الحقيقة احنا لازم نفسح المجال لجلسة أخرى، وبالنهاية أنا أعتذر عن أي هفوة أو هنا في إدارة الجلسة. ما كانت جلسة سهلة، شوية صعبة، وأقدم لكم شكر جزيل وأعلن انتهاء هذه الجلسة المباركة على بركة الله للجلسة الثانية إن شاء الله. شكرا جزيلا. أوكي، كل أي واحد سمع شفت إيد ربعة يصير حديث جانبي.